Hello people, this is Dr. Muskaan this side, and today I'm going to discuss one very beautiful case. It is all about road traffic accident, and they have explored the abdomen. They have decided to do colostomy. They were having two options, either ileostomy or colostomy. They have done colostomy and they have re-anastomosed the distal stoma. And what is stoma? Are there any types of stoma also? So yeah, let's discuss this very beautiful case, and I would like to start this case with the difference of ileostomy and colostomy. Ileum is the part of your small intestine and colon is the part of your large intestine. Ileum has more output as well as liquid, and your colon has your less output, or it has semi-solid part. Your management wise, colostomy is easy as compared to ileostomy. uh, Ileostomy has more skin excoriation as a complication part after the surgery, and colostomy has less. Technical differences: in ileostomy it raises above the skin, and colostomy it flushes with the skin. And there are three types of stoma present. If you can appreciate in this picture, like this I can show you. This is your end colostomy. This means sorry, this is your end stoma, this is your double barrel stoma, this is your loop stoma. And what is the difference between the two? In the end stoma we take out the stoma. In your double barrel stoma we do this, यहाँ से भी स्टोमा, यहाँ से भी स्टोमा निकाला. And in your loop stoma we take out the loop, means if it is a part of your colon we just do like this. So loop is taken out as a whole. And I would like to tell again, end stoma, in this one end is taken out, which is done in our case right now. In double barrel stoma, two ends are taken out with no continuity. In loop stoma, a loop is taken out. And the most common long-term complication of colostomy is your parastomal herniation. So let's start this case. It's very interesting case. And why it is interesting? Because I'm going to tell you stepwise what are the steps of the abdominal examination, inspection, palpation, and and auscultation. Stepwise what I have done in inspection. So yeah, I am interested, I am excited also. I hope you are also too. And let's start. Here is 43-year-old male who has came to ER with alleged history of road traffic accident and with the chief complaint of pain in abdomen. On arrival, ABCS was done, airway was patent. On breathing assessment, respiratory rate was 18 per minute, SpO2 was 94% on room air. On circulation assessment, pulse was 95 per minute, BP was 114 by 84 mmHg, and sensorium was alert, that is GCS was 15 by 15, E4, V5, M6. So A, B, C, S were all good. HOPI patient was apparently asymptomatic few hours back when he went through RTA. He was referred from gyms with alleged history of RTA with chief complaint of pain in abdomen. As per patient, he was driving auto when he hit a truck. His abdomen hit the auto handle, leads to blunt trauma in abdomen. And this part of this history is very important. Why? Because it tells us about the type of trauma. And in our case, it leads to blunt trauma in abdomen. Pain was sudden on onset, dull in character, diffuse in nature, relieved on taking medications. Past history: there was no history of hypertension, type 2 diabetes mellitus, asthma, TB contact, epilepsy, coronary artery disease, or any other comorbidities. Past surgical history: there was previous history of right inguinal mesh hernioplasty 20 years back. Personal history: he takes mixed diet, sleep is disturbed due to pain. Bowel and bladder habits are normal. There are no addictions of tobacco, alcohol, and smoking. On examination, patient was oriented to time, place, and person. He was conscious, alert, and cooperative. General examination: vitals were within normal limits. Pickle was absent, that is pallid, icterus, edema, clubbing, cyanosis, and lymphadenopathy. Local examination: there were on skin. There were two lacerations measuring 3 into 2 centimeter over chin was present. Abrasions on the knee were present measuring 3 into 3 centimeter. Systemic examination. Inspection: there were no scars, no visible lump, no dilated veins, umbilicus is midline, abdomen is round, thoracoabdominal movement of the abdominal wall, abdominal distension was present. How we have seen the abdominal distension? With the help of inchy tape, abdominal girth was measured, and it was increasing trend day by day, 92 centimeter to 93 centimeter to 94 centimeter. And then we have checked that 5F, flatus was passed, Feces was passed, fluid was present, says the USG report. Fat was not present, means the patient was thin. Fetus, of course, how can the fetus be present? He's the male patient. Big tumor absent. So reason for increased abdominal girth is ascites, which is mild to moderate, and hemoperitoneum, which says the CACT report. Second examination was palpation, in which tense abdomen was there, tender, guarding, rigidity was present, diffuse, rebound tenderness was present. On auscultation, there were absent bowel sounds. Investigation picture says that CBC anemic. Why? Because hemoglobin was 9.3 and he's male and it should be at least 15 to 18 के बीच में. KFT shows urea was increased 44.8, sodium was increased 146. LFT report says total bilirubin was 4.85, direct bilirubin was 3.79, SGOT was 55, albumin was 2.46. Chest x-ray says left pleural effusion. USG says mild to moderate ascites. CCT report says hyperdense fluid in perisplenic, perihepatic, pelvic, interbowel regions. Hemoperitoneum might be present. Hemangioma in the segment 7 of right lobe of the liver. HCV, HIV 1-2 were negative. USG fast, E-fast was positive, likely hemoperitoneum is there. So patient was shifted to OT for exploration of abdomen. In the meantime, blood was arranged and the patient was explained the high risk, and post-operative ICU with ventilation was arranged. The procedure performed was exploratory laparotomy with end colostomy with re-anastomosing of distal stoma with previous anastomosis, side jejunum taken out as stoma. Intraoperative findings are anastomotic leak coated at jejunal repair site and sigmoid. 350 gram of blood clot removed from peritoneal cavity. Jejunal loop is taken out as stoma, jejunostomy. End colostomy and primary repair of previous distal ileal stoma. After successful surgery, patient was shifted to ICU. Indications for patient for staying in the ICU was low hemoglobin, so blood transfusion was done and monitoring of the vitals were done. On post-operative day 1, there was one episode of fever, 100 degree Fahrenheit, hypotension, that is 10 ml per hour, NORAD was given to the patient. SpO2 was 97% on ventilation, ACVC mode. Advised was AG charting 4-hourly. POD day 2, BP was 180/90, SpO2 was 98% on mechanical ventilation, FiO2 was 40% and PEEP was 6. He was afebrile. Injection fentanyl for sedation, injection NORAD and injection vasopressin to reduce the BP were there as a management. POD day 3, patient was intubated on ACVC mode, PEEP was 8, FiO2 was 50%, he's maintaining BP on inotropic support. Tachypnea was there, he was afebrile. On post-operative day 4, POD day 4, SpO2 was 99% with 50% FiO2, PEEP was 8, blood transfusion was given by ICU team. There was an anastomotic leak with non-functional ileostomy surgery. Team has planned for re-exploration under general anesthesia. So that's all. I have learned a lot on this case and enjoyed a lot. I hope you have gained some good points listening to the history of this patient. So that's all. Dr. Muskaan Bansal is signing off now.